guys, welcome back to Triple R series, which is on labor and delivery module, which is actually a little tricky and which can actually take away your lot of mark, or which can give you a lot of mark. So I'm going to discuss the tricky concepts, how to do, what to do in this video. Okay, let's start. To start with, remember, always the self-belief is the best one, because you're supposed to be handling your emotions in between the questions when you're doing, right? So always embrace your awesomeness, so rest of the things will fall automatically in place, okay? Okay, let's start with the single best answers. I have created scenarios in such a way that it will able to help you to understand the labor and delivery thing. What I want to say first thing is, remember, labor cases, all the guidelines give you a fair outline of what to do, but there is no black and white rule for the same. Okay. So let's start with this. What is the most appropriate next step? Mechanical heart valve and warfarin was planned to start anticoagulation before delivery at 37. She presents at 35 weeks with gestation and preterm labor with the pathological CTG and 2 centimeter cervical dilatation. So we are dealing with somebody who is an anticoagulant, and obviously it's preterm labor and pathological CTG, and we cannot deliver her. So the next best thing would be to go for cesarean section. Here, the cesarean section thing is, basically this is easier because they've given all perform LSES, proceed with labor is what they have given. But ideally, they should have been option perform LSES under spinal anesthesia. So that could give you an overall picture of what you need to be doing. That could be a little tricky, but please understand, once it's on warfarin, of course, the cesarean section is not because of this. Cesarean section is because of the baby's condition and poor Bishop score, obviously. So the cesarean section which you're going to do will be under general anesthesia because of the warfarin, right? So because warfarin should be ideally stopped 24 hours before surgery. Okay, so that's the reason you're going to immediately do the cesarean section under general anesthesia to avoid the spinal prick and the following which the hematomas, subdural hematomas. Okay, guys. So just think and answer even the smallest of the questions. That would help you to do better in exams. Next one. What is the most appropriate next step in management? Rosina multigravida presented in labor 2 hours ago. She was 9 centimeters dilated with a breech presentation above spine. Now fully dilated with a breech at spines and membranes intact. She is experiencing 3 contractions in 10 minutes. So what they are trying to say is she's actually descending. I mean, she's progressing because fully dilated. Now it is at spine. So what would you do? Because it is breech. She's a multigravida and she's fully dilated now. So please give her in 1 hour and try reassessing. Obviously, if this doesn't work, then you can think of cesarean section, because I think I have a question as well, because descent of the breech, if it is delayed, then you need to think of probably it is not cephalopelvic disproportion, probably a pelvis which is not able to allow the breech to deliver. Okay. Sorry, I've already given you the answer. But let's see the scenario. Nulliparous at a full dilatation has a fetus of occipital anterior 2 centimeter below spines with contraction 3 centimeters below spines. There are no concerns and she has been fully dilated for the past 2 hours. So we are dealing with a primary. It's at +2 and she has been actually fully dilated since 2 hours and it's at occipital anterior. Okay. So as long as they haven't mentioned anything about the CTG, so assume it as normal. So there is no hurry. And with contractions, it is descending down to +3. So you will allow her to push and wait, right? It's a very simple. Once you put the patient in front of you, you can never go wrong. Okay. So just remember, whenever these scenarios come, think of writing down on the paper and imagining that. So that would help you to do better. Next one. So just a minute, guys. So basically, guys, whenever you get these labor and delivery questions, always make sure to, always cross-check these things, because The few things which you must do while answering the labor and delivery question is to understand the gestational age, is to understand the parity, is to understand the position, is to understand analgesia, what she is on, and then from how long she has been pushing the time, as well as probably the associated capital molding. Okay, the next one. Most appropriate next step in management. Multi-parasuman, active labor, occipito-anterior position, level of spines. Okay, I have a multi-occipito-anterior at 0. Okay, she's currently using Entonox for pain relief, but continues to experience significant discomfort. Obstetric team is considering assisted vaginal delivery most appropriate. Let me see the options later. Ideally, a multiparous, which is occipito-anterior, should be able to deliver with the instrument, because she's already has been pushing, and it's like, she would need some help or thing. Right now, instrumental delivery in labor room, instrumental delivery in theater. So just because it's spines, you don't want to push her to the theater. Okay, please remember, it is not that all mid-cavity should happen in theater. It's only rotational mid-cavity and difficult mid-cavity deliveries. You need to be doing it in the theater. Now, once you have thinking where to do, you don't want to do in theater, but the baby's head is at spine. Okay. So to pull the baby's head from spines to the perineum, she needs a good pain relief. What she's on is Entonox, and Entonox might not be sufficient for this, and to keep the pudendal block might not be effective in this case. So that's the only reason where I want to shift her to the theater, probably give her a quick spinal or the epidural, whatever, and then take the baby away. So, take the baby out. So do I have an option here? Yes, I do have an option of option C. Take her to theater, give a spinal, and proceed with the trial. Perform an emergency CS is not. Observe and further distance and reassess in 1 hour. I don't think so, because from spines to down, it would take much more time, which is not required. Continue with Entonox. Yes, she could have done if it was like from the beginning, but not now. Pudendal block and attempt instrumental delivery in the room would have been correct if it was not at spines. Okay, from the spines to perineum, pudendal block might not be enough because it needs a lot of pulling. Okay, hope that's clear, guys. Okay, what is the most appropriate anesthesia option for this patient? 29-year-old woman, active labor, severe pain despite using Entonox. Fetal is engaged at ischial spines. Obstetric team has decided the forceps delivery required to assist childbirth. Pudendal birth, pudendal block, general anesthesia, local infiltration, spinal anesthesia, and theater, epidural anesthesia. Epidural, now I'm confused between epidural and spinal. The only reason the short spinal, why I would want to give is for the quicker action. Please remember, epidural takes 20 minutes to act. So that's the reason. Since she's in a lot of pain, I would want to quickly shift her and to take. Otherwise, epidural is really effective. But because it's slower in onset and I would want to take out the baby because of the severe pain. Of course, CTG, they are not mentioning here. Even if they had mentioned about the CTG, I'm more worried about the severe pain. Okay. What I mean with this question is spinal is quicker acting than the epidural. Obviously, this decision is taken by anesthetist, but as an ST4, ST5, you need to be aware of this. Okay. And one thing you must remember always is know your limitation, right? In obstetric, in OBGYN, as your ST3 or as an ST4, whatever, you must remember that this is an area where you need to take an opinion from your consultant, where you need to know, ask, escalate wherever possible. And they do ask you the percentages about the home delivery and the hospital delivery. So just know them so that you can score the better marks, right? But mostly guys are stuck in labor and delivery scenarios. That's why I'm just sharing this, okay? Fine. The next one, what is the most appropriate next step in management? Don't get worried when the scenario is big. Try analyzing as you move forward, like I'm doing. 32-year-old primi gravida had a slow progress over the past 10 hours. She is 8 centimeters dilated with a deflexed occipito-posterior position. Okay, so a primi deflexed occipito-posterior. CTG shows repeated late decelerations. classified as pathological. She has developed a fever with antibiotics have been administered. You recommend an emergency CS, but the patient declines, expressing desire to continue with vaginal birth as she believes in keeping labor as natural as possible. Okay, so here the ethics is coming into the picture where she's telling in spite of her poor progress and she has developed a fever. So you're worried about probably the complications are probably like a chorioamnitis or probably about the, obstructed labor, whatever. But she's denying for emergency CS. So please remember, unborn fetus has no right. So what would you do further is to escalate the concerns and involve the obstetric consultant because you should know your limitation. Of course, the consultant would speak to her. They would explore her concerns, why she's worried and what is happening, whether she's worried about the CS or pain relief, whatever the concerns the patient is coming up with, and then they try to resolve. But if it still persists, then they have to take a legal opinion and let her continue the labor, understanding the pros and cons. In all these cases, mental capacity of the patient is vital. Okay, let's move on. Easy one. Total fetal blood volume at tongue. So Athena FI1 is learning about mental fetal circulation. So she asked you about. So obviously, these sort of questions are factual recalls. So please remember it is 80 to 100 ml. Okay, per kg. What is the most appropriate next step in the management? Okay, Rosina multigravida presented in labor. 2 hours ago, she was found to be fully dilated. Now the fetus Breech. Okay, Breech who is fully dilated for 2 hours. She is experiencing good contractions 3 to 4 in 10 minutes, most appropriate step. Please remember, if you remember what I said before, if the Breech is checked for 2 hours, you should always think of emergency CS as per the guideline, because if there is no appropriate descent, then you would be really at the risk of delivery for delayed delivery or the stuck shoulders or the stuck probably after coming head. So better to go for emergency CS. Okay, this is in the guidelines, guys. Okay. What is the most appropriate next step? Gravida to para 1, low risk pregnancy, presence at 41. She was transferred from birth unit to labor and pushing for 2 hours without delivery. Okay, transfer to patient because she hasn't delivered. So observation is normal. Abdominal examination less than 1/3, which helps me to understand she can go for instrumental delivery requirement can be satisfied with that. So fully dilated, vertex at spines, right occipital posterior, caput plus and molding plus. So we are talking about a multiparas who has been pushing for 2 hours. CTG thankfully is normal. What is the most appropriate? Obviously, the next best thing is to attempt trial of instrumental delivery in theater because it is an occipital posterior and she is like 2 hours is over and CTG is fine and she is not on any of good analgesia also, but again, right occipital posterior. So she would need a rotational delivery. So that's the reason. You could see attempt manual rotation followed by spontaneous delivery. That's all. If at all, if it was a lower station and if the consultant is there, but it's already, she has been referred for delayed labor. So you need to be careful. Attempt instrumental delivery in labor room, I won't do because of these things. Okay. Yes, guys. And emergency CS, okay, you might actually argue why not emergency CS. Emergency CS is the next step. If the trial of instrumental delivery fails, then we will go for emergency CS. Okay, guys? Okay. The next question, what is the most appropriate next step? Labor ward specialty trainee on call and are asked to review a nully parasomnic, okay, who has been pushing for 80 minutes. And 80 minutes she has been pushing, that is 1 hour 20 minutes, okay. She had a low risk pregnancy and was aiming for water birth, okay. She was found to be dilated 2 hours ago and pushing was delayed until she felt the urge. She's now out of the bowl. CTG monitoring has commenced. She's tired and no longer coping well, okay. From 2 hours, she has been pushing and like not 2 hours, like fully dilated since 2 hours and she has been pushing for 80 minutes. So almost like 3 hours is done, right? So no fetal head palpable, fantastic. I can go for instrumental delivery if required. Fully dilated, fetal headed +1 to spines, left occipito transverse with 1 plus caput, 1 plus molding, like a clear CTG reassuring. So here, continue pushing and reassess in 30 minutes, trial in theater, CS, epidural, manual rotation. So obviously you will be stuck between B and C. And any of these cases, because she's on left occipital transverse, which is a +1. So any of these cases where you are stuck, where unless there is a valid indication of proceeding to cesarean section, you can choose trial of instrumental delivery, because cesarean section is the last option. You choose trial of instrumental delivery. If that doesn't work, then the next option is CS. Okay. So don't think because she's already 3 hours over, let me go and do a CS. No, guys, that's not correct. Okay. Next most appropriate course of action. 30-year-old undergone a forceps assisted vaginal delivery, preparing to suture her perineum using Lignocaine for local anesthesia. Shortly after infiltration, numbness around the mouth and feeling short of breath. So obviously, this is a case of local anesthesia toxicity. So they could give you intralipid also. But please remember, you need to be thinking of what is the next best option, which is stop infiltrating the anesthetic. Okay. So you are actually infiltrating, and see, the question should be very clear that you have started infiltrating, and during the infiltration she feels the numbness, stop infiltrating. Obviously rest of the things. Okay, this is not correct, by the way. Administered, yes, that could be correct. Adrenaline, it depends. Call for anesthetist and prepare for intubation. It all depends upon the like probably status of the patient, and know the lignocaine toxicity and the intralipid dose as well, guys. Okay. Fantastic. So that finishes, I think I have done more than 10 SBS. SBS are also equally bad in L&D. So understand the concept and move on. Let's do the EMQ. Okay. Most appropriate management for the scenarios. A multi-gravida, gravida to para 1 leaving 1, has gestational diabetes and on insulin. She was induced at 38. Baby is large for dates. Second stage has lost at 2.5 hours, and she has been pushing since she was fully dilated. The CTG shows deep early decelerations, 2/5 palpable per abdomen, vaginal findings, vertex at +1, left occipitus transverse slightly defixed, and cap with 2+. So obviously we are dealing with a macrosomia baby with a GDM, and then we are stuck with mid cavity with the left occipital transverse. So the next best thing is, here you might tell me why I can't do the instrumental delivery or the trial of instrumental delivery, which you actually would love to do, right? For example, you have an option D here. But here, you are dealing with a multi, which should catch up your thing is 2.5 hours. Okay. Because a multi-gravida who has been pushing for 2.5 hours. Okay. And CTG is okay. We can still think that's okay. It is not very bad. And also the baby is macrosomic. So you already know that probably you're dealing with CPD. So why to do a trial in theater plus or minus CS? Straight away proceed for the cesarean section. See, it's in contrast to what I said in the last question. Unnecessarily, you shouldn't be moving to cesarean section, but at the same time, unnecessarily, you shouldn't be doing the trial of instrumental delivery as well. Okay, when you know the results. The next one. Primey has been in the second stage of labor for 3 hours. Has been pushing for 2 hours. The head is 1/5 palpable. Vaginal findings vertex at +1. Right occipital posterior with caput and molding, and the CTG is reassuring. Of course, here they haven't given any analgesia. So this you are valid to say that I would move to trial in theater and then without cesarean section. Ideally, trial in theater means that I would try, and if that fails, I'll go for cesarean section. Okay. So here it's at 0, and again you have to give a spinal epidural. I don't know, depends upon what the anesthetist want. Whatever it is, for the good analgesia, you are supposed to be shifting to the theater, and then try. If that fails, you go for CS. Okay. The next one, gravida 3 para 2 Okay, multi-gravida is in prolonged labor. No pole palpable per abdomen, perfect. Vaginal findings +1, left occiput anterior, caput +2. CTG shows deep variable decelerations. There is poor pushing in spite of good contractions due to mental exhaustion. So in this case, you can do the forceps in the room with the pudendal block because it doesn't need a lot of rotation, right? You can do a forceps in the labor room itself. And the reason probably why I don't want to choose caput is two things. One is she's exhausted. You know, in caput, you will need her efforts to push. Second thing, when there is a lot of caput, probably applying vacuum is not appropriate. Okay, let's move on. Hope this is giving you an idea of how different the scenarios could be. Okay, a quicker slide about what to use when, guys. Okay, fine. This I added because I think most of you are still worried about the herpes. Guys, it's very simple. Whoever has active lesions, primary or recurrent, you go for CS. Okay, let's see. 29-year-old, 36 weeks, presents with primary herpes genital infection first time. Active lesions, worried about passing. So I think I have got only one option of cesarean section with intrapartum acyclovir, right? So because of this, I would go straight away for this. Okay, so cesarean section with intrapartum. Next one, history of HSV presence in labor at 40 weeks, no active lesions now, pregnancy has been uneventful except for episode in the first trimester. Her membrane ruptured 3 years ago and she's concerned about transmission of the baby. Okay. So basically, she's worried about the transmission, but she had herpes before. So obviously, you are going to that too in pregnancy. So you give a vaginal delivery with antiviral suppression. Now you know it has to be started from 32 weeks, right? The next one. A 30-year-old woman has a history of recurrent herpes, presence in active labor at 39. Examination, active herpetic lesions are noted on vulva. Woman is concerned about the safety of vaginal delivery and the risk of transmission to her baby. He is not taken suppressive therapy. So obviously, any active lesions you go for cesarean section with intrapartum acyclovir because that's the option which I can see. So again, I've included this because lots of you have been asking about the genital herpes guidelines. Let's move to the next one. Select most appropriate management option. Of course, before looking into all this, I know it is a sinusoidal pattern, but I need to make sure whether it is sinusoidal or pseudo-sinusoidal looking into the scenario. 36-year-old Primey presented with a history of vaginal bleeding. She mentioned 2 paths fully soaked at home, so APH, reduced fetal movements at 40 weeks. Examination abdomen was soft and tender. Fetal heart rate was 160. Scan in pregnancy confirms fundal anterior placenta. Speculum examination. Vaginal bleeding noted. Bleeding was plus, blood loss of 450 ml. There is a tachycardia. Blood pressure is on a little rise. Temperature of 36. Urine dipstick, blood is seen. Protein trace, nitrates negative, glucose negative. So it is continued for 30 minutes. Obviously, here I'm dealing with an APH with a sinusoidal pattern. So I would definitely want to go for delivery of the baby by category 1 CS. Because whenever you apply these concepts, so the answers automatically come in your front. So I'm not even looking into anything. Of course, you need to see whether resuscitate the mother and delivery of the category section if they have given. Because it is not there. It is not that mother's vitals are very bad. They are still okay. There is a minimal amount of tachycardia. So always look for the closest option and then go. Okay. Okay. Here also the most appropriate management. I know the CTG is not good. CTG was recorded in a woman laboring spontaneously at full term in her second pregnancy. First baby had been born by CS. Okay. Previous CS now. Because of failed post-op induction, trace was recorded, 4 centimeters dilated. Okay. So I am dealing with the previous CS woman for VBAC and she's 4 centimeters dilated and this is what the CTG is all about. Obviously, see, you can see a variable deceleration, which is W pattern. And this is also, you can see a very typical W pattern here. And there is fall and there is rise and again it is dipping. I know that even if I don't want to interpret the CTG, I know she needs a delivery because she is just 4 centimeters dilated. Now, only these two things, that is category 1 or category 2. Please remember, unless the mother or the baby in jeopardized condition, you would go for category 2 for this. For example, abruption, rupture, or if at all, if you have a cart prolapse with abnormal CTGs, shoulder dystocia, prolonged bradycardia for more than 3 minutes, all that automatically account to category 1. Rest of the cases should be going for category 2 because category 1 is quite traumatic. And also it could be like, it is done generally under GA if they're not on any anesthesia and our analgesia. Okay. So that's the reason delivery of the baby by cat 2. Okay. So this is what the explanation is. So this is a pathological CTG and how would you take about it? Okay. Okay. Again, few labor scenarios to help you to understand. So again, appropriate management. 20 Mrs. Emily, 37 weeks, primary gravida, low risk pregnancy, active labor, fetal head is on perineum. She has been pushing for 2 hours with no concerns. She is currently using Entonox. I don't think there is any problem for her. So she's primary 2 hours with Entonox, head on perineum, let her push, right? Nothing to be done. So quite simple. Don't say that, okay, I'll push. I will go ahead and, put instrumental delivery. Even if she has crossed like the stipulated time for primary 3 hours and you have that nice guideline, right? But somebody, even if they've crossed that time and she's about to deliver, don't apply forceps or vacuum. Okay, so you let them deliver because that is a guideline which is giving an information about how to go about, right? And what is the deadline which you cannot cross. It doesn't mean that once time is done, you have to put forceps or vacuum. Okay. Let's move to the scenario 2. Mrs. Sarah, 34-year, multigravida, 39 weeks, pushing for 2 hours under epidural. Fetal head is at stationary spines in occipital anterior position. Okay. So she is on epidural and she has been pushing for 2 hours and it is still at spine. So what do? Obviously, you have to help her to take the baby out. And now you must be thinking, okay, she's spines. Let me take to the theater. No need. Because a multigravida who doesn't need a rotational delivery, which won't be difficult because it's occipital anterior. She's on good analgesia. So go ahead and deliver her in the labor room. Okay. And this is what I was trying to tell you guys, that all instrumental deliveries, especially the mid-cavity, need not be in the theater. Okay. Mrs. Lara, gravida 2, that's multipara 37, BMI of 38, fully dilated for 2 hours, right occipital posterior, stationary spine, epidural analgesia, struggling to push effectively. Here, I would definitely want to go ahead with the trial of instrumental delivery because I know that there will be a increased risk of failures because of the obesity and the right occipital posterior. Even though it is multiparas, I don't want to take the risk even with epidural analgesia. Hope this is clear. Miss Jane, 38, multiparas at 38, has been fully dilated, pushing for 2 hours. Fetal head is 1 centimeter below scale spines, left occipital anterior with caput and no molding. Okay. So again, here I'm dealing with an occipital anterior with a caput and no molding, but the problem is about the analgesia. Okay. But so again, multiparas, but she doesn't have a good analgesia, then I would want to shift her to make her labor easier and quicker. Okay. So basically, guys, this is what the final gist which I've discussed in all the scenarios. Somebody who is a primary low risk, even the time is over, please let her push. If it is difficult rotational deliveries, you can shift to the theater. If they are not on with or without good analgesia, shift them to the theater for a trial. If somebody is at spines like primary or a multi with occipital anterior on a good analgesia, you can deliver. If you are not expecting difficult deliveries, you can deliver in the labor room. Basically, the whole point is to make you understand there could be variant scenarios. Read the scenario carefully and answer. Hope this has been helpful, guys. Thank you so much. May success be yours.